Welcome back to Plastic Surgery Decoded, the podcast designed to help you better understand plastic surgery. We take the mystery out of it in plain language. You'll find it interesting and useful whether you are already planning a procedure or you're just curious. I'm your host, Dr. Regina Newhan, and we are now into Season 5 of the podcast. After you listen to this episode, know that you can explore and enjoy many other topics, either through your favorite podcast app or through the website at plasticsurgerydecoded.com. The first 40 episodes, or Seasons 1, 2, and 3, comprise the Plastic Surgery Decoded Classics, with my singular voice covering cosmetic and reconstructive procedures, skincare, and general questions about plastic surgery. The remainder of episodes, Seasons 4 and 5, are interviews with my colleagues around the country to help you learn about the subject. A great variety to choose from. Remember that this podcast reflects my experience and opinion, as well as those of any guest interviewed. It is not intended to provide medical advice, nor is it a substitute for a formal consultation with your physician. So come along with me as we explore this ever-growing world of plastic surgery. Let's go! Losing a breast to cancer can understandably be a devastating experience. And the advent of breast reconstruction has been invaluable in helping mitigate some of the physical and psychological impact. But a lot has changed over the many decades of this important field of plastic surgery. There are improvements in previous techniques, as well as newer options and trends. What could be around the corner? Maybe robotic surgery and new biologic fillers as an alternative to an implant? The future potential is exciting. In this episode, we hear from Dr. Scott Hollenbeck, a leader in this realm, as he shares with us insights on the state-of-the-art of breast reconstruction. He sheds light on the decision-making process and gives us an idea of what's next to come. Listen to our conversation. Well, today we are lucky to have with us Dr. Scott Hollenbeck, who is an internationally recognized plastic surgeon, and he's the immediate past president of the American Society of Plastic Surgeons. Now, currently he's practicing at the University of Virginia, where he is chair of the Department of Plastic Surgery. And actually, that's where I got my undergrad degree, so I have a little soft spot for UVA. Welcome, Dr. Hollenbeck.
Well, thanks, Dr. Nohan. Nice to join you here today on the podcast.
Thank you so much. You know, you are a well-known surgeon for your skill in reconstructing a breast after removal for cancer or mastectomy. But are these the majority of patients that you treat in your practice? Could you tell us what the breakdown of types of cases you typically see is?
Sure. Yeah, I do work in an academic center, as you pointed out. And so generally speaking, we accept and take care of all patients. However, most of us do specialize in something, and for me, it is breast cancer care and microsurgical reconstruction. So that does involve other things. It could include lower extremity trauma, could also include head and neck, could include chest wall reconstruction. But my main area of focus is breast cancer reconstruction. About half of that is autologous tissue or free flap reconstruction. And about half of that is implant-based reconstruction, and then other modalities, which we'll get into as we go into the podcast.
Yeah. And by autologous tissue, you mean using the patient's own body tissues?
Exactly. Yeah. What's commonly referred to as flap surgery.
Yes.
But there are other aspects of that, fat grafting and some other things, which we'll talk about.
Perfect. Well, you know, we're here to talk about breast reconstruction after mastectomy. And overall, I'm curious, do you find that there are fewer mastectomies being done now, perhaps in favor of less invasive cancer removing procedures? In other words, are we doing more reconstructions or less these days?
Yeah, that's a very, very good question. And I think that is the case. Overall, the data is not so clear in this regard, in part because it lags behind. But some of the data coming out of the large cancer databases and even some smaller centers do indicate a trend towards more and more breast conservation. That is lumpectomy and then radiation. That's been shown to be equivalent, at least in terms of survival, compared to mastectomy for certain types of tumors. And so many centers are now favoring lumpectomy and radiation over mastectomy.
Hmm.
And I would say that the trend overall is heading in that direction. I think when I first started my practice, it was closer to 50-50 in terms of all patients coming in with breast cancer. 50% might have mastectomy, 50% might have breast conservation. Now we're getting closer to 60-40 lumpectomy, radiation, and perhaps even 75-25, with discussions at the national level of goals, even at the 80-20% range of breast conservation, which I think is, overall great. Obviously, mastectomy is more surgery, more disfiguring, if you will. But there's caveats to that, which I think are important to consider. Some tumors are quite large, extensive in nature, and that application of breast conservation can lead to some problems. The other issue is the radiation. As a plastic surgeon, this radiation is literally, the worst thing that we deal with in terms of tissue handling and tissue recovery,
Right.
wound healing. Radiation is just so difficult to deal with that it is hard to manage problems after radiation has happened. So I think it's an evolving topic, but yes, you are correct. The trend seems to be heading towards more breast conservation with lumpectomy and radiation as compared to full mastectomy.
Yes. Well, for those patients who do undergo mastectomy, why is breast reconstruction so important physically and mentally? Isn't the breast just an organ that has served its purpose once childbearing is over? And I'm being devil's advocate here, of course.
No, of course, that comes up a lot. And I was even reading an article just the other day that had that exact same phrase in it. A lot of this comes down to personal decision, to be quite honest. I think that somebody could make a decision not to undergo any type of reconstruction. And that is becoming also more and more common. And the old way to do that was simply to do nothing, just have the mastectomy and close up the skin. The downside of that is there was often a lot of extra skin left over.
Hmm.
Because no special attention was paid towards getting the closure to be smooth and to look as good as possible. I would say now there's a lot more emphasis on what is called the aesthetic flat closure.
Hmm.
A lot of this being driven by patients, actually, where they are asking for this additional focus to be placed on the smooth closure. And so many of us as plastic surgeons actually offer that as a reconstruction, if you will, not to reconstruct the breast, but to make the final outcome to be optimal in terms of what the patient has requested. And so, in my mind, that's also reconstruction,
Sure.
meaning that we have done something to try to help the patient.
Recontouring the chest. Absolutely.
Yeah, contouring, and that's again a patient decision. And I think the key to all this is trying to develop informed consent and education with the patient. Obviously, it's impossible for any individual, any patient to know everything and be able to understand all the nuances of everything. You just can't until you go through it, I suppose. But getting as much information as possible is really helpful. And one thing that's really changed the game and all that is patients relying on other patients to get information
Yes.
with social media and other platforms such as this podcast and other things. Patients are able to actually connect at large scale with other patients and get information about what they went through. And that really has been an important part in the patient decision making as it pertains to things like, should I get reconstruction or not?
Absolutely. And what about, I hate to say it, some of the naysayers, though, who have not experienced what it's like for a woman to lose a breast, and those people who say, "Oh, you don't need a breast. It's just superfluous."
Yeah, it's so fascinating. It's interesting. I've seen all sorts of perspectives over the years. When all this started a long time ago with mastectomy surgery, reconstruction was felt to be something only cosmetic seeking patients would pursue.
Mhm.
And at that time, it was not even covered at all by insurance, and only those that had means, as wealth, would pursue types of reconstruction. And then it was felt that that's not great. More patients should have access to breast reconstruction. So a lot of work was done to expand the options for patients. And so the Women's Health Cancer Rights Act was passed to expand the
Yay.
access to breast reconstruction. Yeah. And then a lot of people started getting breast reconstruction. And in fact, we were really pushing, if you will, or at least making that option available for patients. And then almost it got to be maybe too much where patients felt like, well, I didn't really know all the details. Maybe I didn't want this. So it's kind of like one of these pendulum things where in the past it wasn't available. That wasn't good. Maybe at one point in time, there's too much being offered. I think there's a kind of a nice area where patients are at least informed about it, but not made to feel like they have to get it done.
Yeah.
And that there's something wrong with them if they don't get breast reconstruction done. It's a personal decision. And, you said that phrase, they've done their job. Why bother getting reconstruction?
Right.
It's part of your body, basically, that is removed or amputated, whether it's done its job or not. It's part of your body.
Mm-hmm.
And so when part of your body is removed, that's not something you would just say, oh, it doesn't matter because it's done its job. It is
Missing. Yeah.
it's a disfiguring aspect. The goal of breast reconstruction is not to look good in a bikini, so to speak. It's more about restoring the individual's, sense of wholeness and their body, so to speak, and trying to relieve any kind of discomfort that may exist and allowing clothes to fit properly that maybe are very difficult to do that. So it's all these other things, perhaps besides what somebody might think initially when they're encountering this topic.
Sure. How do you find insurance coverage for breast reconstructive procedures to be these days? Is it relatively straightforward? Is it difficult to get coverage? What do you find in your practice?
Oh, yeah, that's a really contentious subject, across the board, obviously, insurance coverage and healthcare in general. I would say overall, at least in breast cancer related reconstruction, there is this law, if you will, the Women's Health and Cancer Rights Act. And that forms a foundation for protection of these services. The bigger issue we get into is some of the details around it and the fact that things evolve. So that law is fairly old. And so the treatments and the surgeries and the options have evolved. And so we find more and more that these newer treatments, these better treatments now, if you will, sometimes are denied. And that is more of an issue. So actually, just a day or two ago, it was announced that the introduction of the modernization of the Women's Health Rights Cancer Act was introduced.
Yeah.
Bipartisan support. ASPS was a big part of pushing this out. And we hope that that will allow for some of these new techniques, new approaches to also be covered. But this is part of what people really struggle with is, hey, I want to provide these services, but the reimbursement is either difficult to establish or is exceptionally poor, such that I just don't want to do this anymore. I can't do this and pay my staff or maintain an office. And we hear that time and time again. That is unfortunate, especially in the context of insurance payers that seem to be financially doing quite well. It is hard to understand how some of these services are reimbursed so poorly. But this is a complex debate and it's an ongoing debate. And we hope that there'll be some further improvement as time goes on. But it is not looking good the last few years, unfortunately.
Yes, very unfortunately. Well, for those who are maybe not quite as familiar with breast reconstruction itself, could you just explain the concept and some of the options? A lot of people think of just put an implant in, but what else is there?
Yeah, and I mentioned earlier about breast conservation surgery and lumpectomy. And I would say there is a whole spectrum of reconstruction done in that arena as well. So it's not just take out a little piece and close it up. There are now options that have been around, but they're becoming more and more popular where rearrangements of the breast are done at that time.
Yes.
And that can be things like a breast reduction or a lift. something like that that addresses other problems at the same time as removal of the tumor, and those are called oncoplastic surgeries. So
Hmm.
that's very, very popular now and seems to be growing, especially as lumpectomy surgeries seem to be growing as well. As we shift into mastectomy, those are more complicated and more challenging because more tissue has been removed. And there are generally two approaches there. One is using a device or an implant. The other is using the patient's own tissue. I mentioned that earlier. Those are usually called flaps. And by far the most common type of flap used is the abdominal based flap, the so called deep flap. And those are kind of the two distinctions. Now, to get one of these flaps done, you have to have enough tissue, obviously, to do that.
Hmm.
And not every patient has enough tissue. Not all patients want to have that surgery. It is a little more complicated, it is a little longer. It does result in a second area on your body that is injured, if you will, or that has a new scar.
It has to heal.
Yeah, and so some patients do not want to go through that and would prefer to have the implant approach, which is a little bit easier in that way. You just simply take the implants out of the box and put them in. There is no additional cutting that's needed for that. Downside to the implants is they're not natural tissue. They are synthetic. They're filled with silicone. We believe they're safe, although that has been a debate since the beginning of the implant history and something the FDA follows very closely. But they do need to be changed and they need to be updated and replaced approximately every 10 years, whereas the tissue is kind of a lifelong result that lasts forever. Tends to age fairly naturally. It tends to be warm where the implants can be a little bit cooler, tends to feel fairly natural, feel fairly soft.
Yes.
I generally find that my patients that get the tissue flaps generally feel a little bit better. Downside being that they have, some of these problems with their belly, the abdomen, but we try to do the surgery in a way that really minimizes those abdominal problems and then get the full benefit out of the tissue for the breast reconstruction.
Yeah. Well, you mentioned the abdomen as one potential donor site or source of tissue that you can move into the breast area to reconstruct a breast. But are there other potential donor areas? What are the choices?
Yeah, there are alternative areas that are, not nearly as common, but are options.
Right.
And they're not as common because they're just simply not as good typically, in part because tissue doesn't quite hang in an easily removable way
Hmm.
as it does in the lower part of the belly. And the scar and the closing doesn't quite end up as favorable as it does with the belly. But these other options are generally located in the thigh region, so the inner thigh or the back of the thigh. Those are other flaps called the tug or the pap flaps. And then other options include the buttock or the lower back. And those are additional options as well. Again, you can imagine you don't really have that sort of hanging tissue there. So usually a fair bit of work has to be done to close those areas up so that it's smooth. Also, those types of tissue flaps tend to not be as big or as full as the belly flaps, which tend to match up quite well to the natural breast
Yeah.
size.
Can't bring in as much tissue. Yeah.
Yeah, so they're not quite as good for that reason, but they are certainly options if somebody's already had, say, a tummy tuck in the
Hmm.
early part of their life.
Good point.
Yeah, which does happen occasionally, and now they have a breast cancer. They prefer to have a tissue reconstruction. We start looking around for those alternative options on the thigh and the buttock region.
Hmm. And I just wanted, you talked about oncoplastic procedures, these phrases that some people may not have heard of before. What is a nipple sparing mastectomy? And does that make reconstruction easier?
Yeah, nipple sparing mastectomy really popular about 10 years ago, caught on as a nice option. A couple of things about that. It's been shown to be safe from a cancer standpoint. We don't have a heightened concern that the cancer is going to come back in the nipple if done, properly by most breast
Hmm.
surgeons now know certainly how to do that.
Yeah.
That's number one. Number two is it actually makes the surgery more complicated. I think that's fairly clear. When you save the nipple, there's a couple things that happen. Number one, you're saving all of the skin. So your chances of having skin that is poorly perfused, blood supply becomes a problem. And so you can get skin necrosis. And that's the thing that tends to happen a little bit more commonly with nipple sparing.
So it doesn't survive.
Yeah, and the incisions become sometimes off to the side, and it makes the surgery a little bit more challenging, a little harder to see for the breast surgeon. And so we see some difficulties at times. So I would categorize the surgery actually as a little bit harder. There's also some concern about infection rates, things like that. As you divide, through the nipple, there is concern that there's bacteria that are in the nipple ducts, and those can cause problems related to infection. That has yet to be definitively proved, but we do have a concern about a higher rate of infection with nipple-sparing mastectomies.
Mm-hmm.
And so for all those reasons, I categorize it as a little bit more challenging. However, the outcome is superior in terms of how it looks, at least. You have to realize, of course, and we always want to make sure we tell patients this, the nipple does not typically have feeling left after the surgery.
Right. That's important.
Yep, all of the nerves, all of the tissue below are removed. Now, there is work going on to try to recreate the nerves that go up into the nipple. I would still categorize that as work in progress. It has not, definitively been shown to be something that can be done reliably. Certainly in an advanced cancer, really hard to save the nerves and all that.
Yes.
Yeah, but there are scenarios where you can try to preserve some of the nerves and all that, maybe in a prophylactic case. But nonetheless, the typical patient that has a nipple-sparing mastectomy, the nipple is mostly numb, but it does look a whole lot better without clothes on. Now, a lot of people aren't worried about that. They're more concerned about how they are going to appear with clothes or with most types of clothing. So presence of the nipple doesn't matter to them as much. And so taking on those extra risks that we talked about a little bit earlier become less important. And so those patients may choose not to have a nipple-sparing mastectomy. But for a patient that is concerned about how they're going to look without clothes on, an example of that might be a younger patient who is, actively dating or something like that.
Yeah.
They may very strongly prefer to keep the nipple. And in those cases, we may try very hard to do that.
Gotcha. Well, we've talked about, some options here of reconstruction. How do you decide who is a good candidate for implant reconstruction and who would be better served with a flap? And does the type of planned mastectomy, just like we were talking about, or the shape, size of the original breast have any bearing on the type of reconstruction that you recommend?
Yes, great question. And this ultimately is the so-called $1 million question, yeah, this is the question everybody wants to focus on and talk about in a consultation, because this is the big decision.
Sure.
And I would say you can sort of break it down pretty easily in a couple ways. The first one is, have you had radiation or will you get radiation at some point in your treatment? If the answer to that is yes, then we really want to start thinking about the tissue flaps. In general, radiation and implants just do not mix very well. Occasionally you can make it work and you can get lucky and you can get by and it can hold up for a little while. But generally speaking, radiation and implants do not work, either past radiation or future radiation.
Mm-hmm.
And I have also handled and dealt with a lot of major, issues and problems with that. And when you talk to people out there in the world that have had major problems with breast reconstruction, that's usually the formula there: radiation and implants.
Mm-hmm.
And so we want to try to avoid that, generally speaking. So that's number one. Number two is, if they're having a one-sided mastectomy and their other breast generally does not look like an implant, then we need to think about a flap at that point. So most natural breasts do not actually look like an implant.
Mm-hmm.
Most people are probably familiar with implants. They're generally round. They don't have a natural sort of breast shape to them. But occasionally, some patients have a natural breast that sort of looks like that. And in that case, you can match that with an implant.
Mm-hmm.
However, if they are like the majority of women, their natural breast does not look like that. It looks more like a teardrop shape and has a certain amount of ptosis or a hanging component to it. You simply cannot match that with an
Mm-hmm.
implant, in my opinion and many others' opinion.
Even with the teardrop shape implants, it still does not look like a breast. Yes.
Does not, yeah, it doesn't look like that usually. So generally speaking, a single mastectomy, I'm always thinking about a flap for that patient.
Makes sense.
Now, a double mastectomy,
So both sides, yeah.
you're going to put in two implants. They're going to look exactly the same. And most people really do value, symmetry.
Mm-hmm.
And so if you can get the same exact implant on both sides, you're going to do okay. Again, no radiation, same implant on both sides, nipple sparing, that can begin to look
Mm-hmm.
pretty good. And most patients are pretty happy with that. And on top of that, if they do not have any belly tissue, that's the other
Yes,
thing.
yeah.
So
Not much to work with, yes.
yes, the value of the donor site on the belly. So if somebody's been thinking for the last 10 years, gosh, I hate my belly, I wish I got a tummy tuck someday, and then all of a sudden they're dealing with this breast cancer problem, and part of the solution is to take the belly tissue and use it for the reconstruction. That's a value add that maybe it's not the reason to do the surgery, but it sort of adds a little bit of value to it.
Great point.
Yeah, but if their belly is nice and flat and they've always sort of liked the way their stomach looks and all that, doing a flap surgery in that patient is really not a great idea.
Mm-hmm.
And so that makes you really think more about doing the implant surgery. So it's those sort of things that kind of play into that decision about it. But number one is the radiation and implants.
Mm-hmm.
Yeah, I try to avoid that.
Well, that's great insight about decision making. And you touched on a subject, I just want to ask you a question about it. For those patients who just have one sided mastectomy, how often are you having to do something to the opposite breast to create symmetry?
Yeah, that's a great question. That comes up a lot. Fortunately, that is part of the coverage for this.
Insurance coverage, yeah.
Yep. If a patient needs something for symmetry, we'll do that. So I don't usually push that on a patient, and hopefully not many of us do. But
Mm-hmm.
I'll just sort of ask them, how do you like your other side, and have you ever thought about any procedure for your other side? And you'll usually get some kind of response. Oh, it's fine. I like it, or something.
Yes.
Or, oh gosh, I wish I was smaller, or something. And now you're thinking, oh, maybe a breast reduction, or you start off the whole consultation, how would you like this to turn out? Well, I would like to be way smaller than I am now. Well, obviously now you're thinking we'll probably do a reduction on the other side.
Mm-hmm.
Or you see a patient who's a little bit older, who's had kids, and it's quite obvious to you, and you probably will find out from them very quickly that they would also like to have a lift component as part of their reconstruction. And so now you're thinking, well, probably the other side, they may want a lift component as well to achieve symmetry. But I would say overall, it's probably pretty close to 50%
Mm-hmm.
of the patients end up with some kind of procedure done on the other breast to achieve symmetry.
Gotcha. Well, we've talked a little bit about radiation and some of the deleterious effects of that. Let's also talk a little bit about chemotherapy, but for both of those, what we call adjuvant treatments, do those affect the timing of your planned reconstruction procedures, or how do you look at that?
They do. And, I mentioned radiation being such a huge problem with surgery. Chemo, not as much, but obviously you don't want to do a lot of surgery or anything during chemo. And the patients need time to recover from, the serious big chemo that we're all sort of familiar with.
Mm-hmm.
The thing that's become more interesting now is the explosion, if you will, of all these other types of chemo, so-called targeted chemotherapy or immunotherapy, which is great. And the science has really taken off and it's really amazing. But it literally is almost like every week there's a new chemotherapy drug out there that only goes after like a single target in the whole cellular pathway. And a lot of these have some data, of course, to support their use. but there's not a lot of data related to the impact on reconstructive surgery.
Yeah.
So we are a little bit sort of uncertain as to how these are going to impact our timing and wound healing and so forth. And some of them do impact wound healing, and we've seen that, unfortunately. And I've written a paper or two about that with some of these medications. And we're even observing some newer things with some of these brand new medications related to adrenal insufficiency, for example, things you wouldn't even really expect or see to be related to your surgery. So I think the bottom line is, if it's a kind of chemotherapy where you can have hair loss and lose your blood count and that sort of thing, we need to wait and let the patient recover. And that's usually a minimum of 6 weeks
Mm-hmm.
off of that kind of chemotherapy. And then I try to do the least amount of surgery as possible at that point. So, for example, if they have a bad tumor on the right side and they need neoadjuvant chemo and they get that and they lose their hair and they get a little bit sick and blood counts drop, have to go to the hospital a little bit, and then finally get through all that and come back and start to recover. And now the planned surgery is to do a double mastectomy and reconstruction. I would say let's just do the cancer side.
Yes.
Don't There's no reason now to do the left side that doesn't have cancer in it. We can do that later. But we've got to do the cancer side now because we need to do it, right after the completion of chemotherapy. And then the other thing is I try not to do, let's say they wanted to do flaps. That's a bigger surgery. So I would
Sure.
instead put in a temporary tissue expander at that time, more likely than do, a double mastectomy and double flaps on a patient that is just recovering from chemotherapy.
Great point.
Yeah, that's the approach. Try to minimize what you have to do surgically to the absolute necessities and then let them recover and then come back and do whatever else is necessary.
Yeah, that sounds great. And for the listeners, a tissue expander is basically a balloon, if you will, that is a temporizer and helps hold a place, stretch tissue out a little bit until you're ready to put an implant or a flap in.
Exactly.
Well, if the nipple is removed with a mastectomy, reconstruction of that nipple is often a separate procedure. Does everybody have it done? And what is the timing of doing that?
Yeah, that's an interesting one too. And it's a little bit more of a fun one because it usually means we're sort of towards the end
Yes.
and we're wrapping it up and we're making some final sort of finishing touches.
Yeah, it's a happy surgery.
Yeah, usually more of a happy surgery. And the decision making around that is twofold. So, first of all, is do we want something that sticks out or do we want to keep the surface flat? Basically, do we want to make a little skin cylinder or some type of projecting nipple or just a tattoo?
Mhm, like a 3D tattoo that looks real but flat. Yeah, good point.
Exactly. And so many patients like the fact, especially if they have implants in, like the fact that they do not need to wear a bra
Mhm,
and they do not want to have a nipple appearance through their shirt. So they would prefer a tattoo in that scenario.
mhm.
However, there are some patients that like to have a little nipple show or something. And so they might want to have that actually created. So you have to ask the question.
Mhm.
And then the other thing is if they've had the one sided mastectomy and have a natural nipple on the other side, usually we will try to recreate a projecting nipple in attempts to try to match the other side and then tattoo it afterwards. So that's a two-step process. Create the projecting nipple and then tattoo it afterwards.
Gotcha.
But I would say for most of the patients that have had a double mastectomy, non nipple sparing, many of them prefer just the 3D tattoo only.
Boy, they can look so good too, so realistic.
Yeah,
Yeah, and as far as the, projecting nipple, I recall a patient I had who had a really overdeveloped nipple on the other side, and so we did a compromise. We, made a projecting nipple on the reconstruction side and reduced her other nipple, then she had better symmetry, and she was very happy, so
yes, and there's even another version of that where you take his nipple share version, where you take a
yes.
component of that and graft it over, and I've done that a number of times as well.
Borrow from the other side to reconstruct the cancer side, that's
That's
great.
right.
Well, I also wanted to ask you, there are recent articles about bioengineering 3D printing of a nipple implant. And it could be like a scaffold that tissue could grow on, or sometimes there could be cellular components added. Do you have any thoughts about that? The way of the future. It's not mainstream yet, of course, but
Yeah. Yeah, those kind of things have been proposed and been around a little bit for nipple reconstruction. I think more applicable for other things, and I do have some thoughts on that. But for nipple, you need the skin, to hold it and house it, and then these little synthetic or biosynthetic scaffolds or structural components tend to struggle a little bit in those little skin arrangements. So I'm not particularly a big fan of that. But one of the problems we do have with these nipple reconstructions is lack of projection.
hmm
And even if you make the biggest nipple you can try to make, they just lose,
they flatten out.
they flatten out.
Yeah, frustrating.
Yeah. So maybe, for some patients that really, really want, or you're trying to match like really strong projection, maybe these would be something you'd try.
Yeah, makes sense. Well, what about other finishing touches to make the breast look more realistic, perhaps? Can you tell us a little bit about fat grafting,
Yes.
filler? And I know you've been doing some research on soft tissue filler, but can you just tell
Yep.
us what would be the role for those types of things? How would they help?
Yeah, yeah, exactly. And I think this is exciting because we've talked only really about flaps and implants, which I view those as sort of a base, a initial sort of component.
To create a mound, basically.
Yeah, but not the finishing touch by any means,
Yeah.
because they're a certain shape, a certain size. We already discussed how implants aren't a natural shape. So you need something else to add to it. And often the edges of these things are very obvious and they don't
hmm
blend in well with the rest of the body. So fat grafting usually is the answer to that, in my opinion. And I do a lot of fat grafting. Almost every one of my breast cancer patients, whether they're a flap or an implant, ends up with fat grafting.
Yeah.
And in fact, probably the implant patients get more. And so I usually will place an implant and then on a separate surgery do quite a bit of fat harvest and then inject the fat on top of the implant to add a layer of padding, which helps a little bit actually with the warmth. We talked about how they can get cold.
Yes.
It adds a little bit of padding to it, and then it also camouflages the implant a little bit.
The edges. Yeah.
Yeah, it gives it a little softness as well and turns it into something a little more like a flap, a little more natural.
hmm
So that to me is really exceptional. And then for flaps, you can take a flap that's kind of small and inject fat into it and make it much bigger because the flap has all this blood flow and blood vessels in it. And when you inject the fat into a really good, well vascularized area, it tends to survive and tends to do well.
hmm
When you inject the fat into really poor area, it does not survive. And so fat gets a bad name because it's often injected into a suboptimal area, either a pocket where it just floats around or injected into bad skin or bad tissue.
Yeah. Can't do its job then. Yeah.
Yeah, it can't do its job. So for me, for example, some people will take multiple flaps, like 4 flaps. I prefer to take just 2 flaps for a double mastectomy, 2 flaps, and then later do extensive fat grafting and inject the fat into the flap.
Great idea.
Yeah, because I feel like I can get equivalent volume with less of the donor site problems seen
hmm
in the thigh based flaps that we talked about a little bit earlier.
Yeah.
So I love fat grafting. It is an extra surgery and it does take some time to recover from, and it can lead to problems too. There can be discomfort where the fat grafting's done or the liposuction's done. And the bigger problem that I encounter is contour irregularities.
Mm,
When you kind of over suction an area,
sure.
you can get these little irregularities.
Divots. Yeah.
Yep, and that bothers patients. And then we sometimes have to go back and try to fat inject into those areas.
All right. Exactly. Well, all told, and I know it's different for each individual patient, but when patients come into your office for consultation and they want to know about the big picture, the whole process, overall, What do you tell them in terms of length of time to expect before everything might be done? And given that it might be multiple stages, what kind of a psychological toll can that sometimes take on the patient?
Yeah, it's such a good question, and I think it's so important. My general approach, which I hope has worked well, I think it has for me, is number one, I certainly try not to sell anything at all. Like, this is not a cosmetic procedure. This is not, hey, this is fabulous. We're going to make you beautiful. And I mean, it's more of a supportive thing, like I'm going to do my best for you. And this is a difficult situation that you're in, and I'm here to try to help, and I want to listen to you, and we're going to work together. We're a team, and that's a big part of it. And I try to make sure that we talk about all the potential downsides to everything, and I do emphasize that it's a bumpy road, so to speak,
Hmm.
that nothing ever goes perfectly well, and there's always some things that come up, and it never turns out exactly the way we thought or hoped for, but it is manageable and we will get through it. And my goal is that at the end of it, we still like each other and we wave goodbye and you return to your life, intact
Yeah.
and in a productive way and in a way in which you're happy and can live your life the way you want to. That's sort of the promise that I make. And we try not to do as all these surgeries, but sometimes I tell them there are multiple steps. So I usually say it's a year. This is going to be at least a year.
Yeah, that's a good time frame.
And we will get to know each other really well, is usually how I frame that.
There you go.
Yep.
Well, I think it's wonderful that you and your team are so patient focused, and that's really what the patients want, after all. And along that line, I'm wondering if you could tell the listeners how meaningful your dedication to this surgical service is, and how important breast reconstruction can be to a person's well-being.
Oh gosh, yeah. I mean, people might say that don't do this type of work, and this happens all the time in the hospital. Like when you're in the hospital setting, you're around like the cardiologist or the transplant surgeons or whoever, neurosurgery, and everybody feels like what they do is the most important thing. But it's all important. Some aspects of healthcare are at the end of somebody's life,
Hmm.
but other things occur during very important stages of their lives. And many times, breast cancer is one of those things. Oftentimes, somebody's in the middle of the most productive and busiest time of their lives. They have children or they have big job going on and all this stuff. So it's usually a pretty big deal. And getting through it and having a decent experience can be very, very impactful. Anybody that's been through it understands that.
Hmm.
But for those that haven't, they just have a hard time understanding even why we bother doing this and why anybody would bother doing this or anybody cares. But I have, as I look around my office, I have tons of handcrafted gifts that patients have given me, paintings, drawings. I have an entire 2 or 3 drawers filled with handwritten letters.
Oh my gosh, all tokens of their appreciation. Yeah, wonderful.
I'm sorry I can't show it to you on the podcast. And
No.
on and on and on. And I'm not saying that to brag or something like that, but I'm saying that because I am certain, beyond any question or any doubt, what we do in this area is incredibly valuable and incredibly important
Hmm.
for these patients and their families too. A lot of these family members are just unbelievably grateful when their spouse or their sister or whoever is going through this. You can tell that they have also gone through it to some degree with them and they live with them and they see how much it's impacted them. And you can imagine the dynamic on a day-to-day basis, what they're going through. And when you can get through it to a place where they can return to their lives again in a way that is okay, then that's incredibly valuable. And so people like to share that with you. And so I'm very proud of what I do. I'm very
Mm,
proud of all the other plastic surgeons that do this and other types of work. As you know, as a plastic surgeon, it can be difficult to relay that to the general public. It can be
yes.
difficult to relay that to other people in medicine, but I have no doubt about that.
Oh gosh. Well, that's a beautiful way to end things. But curious, could you tell us what do you think might be coming in the future? for breast reconstruction? Is there anything on the horizon now or anything you would like to see that we just don't have yet?
Yes, there's a lot going on, and I'll go through a couple things. One of which I'm working on myself, and I'll talk about that. But let's talk first about kind of technical advances. One is in robotics. There is minimally invasive approaches now for mastectomy with robotic surgery, both to remove the breast tissue, robotic mastectomy, and then robotic reconstruction.
So cool.
And that is very, very early on and will continue to evolve. But I would say overall, robotics in surgery are growing. I don't mean AI, like where there's an actual robot,
Right.
but where it's
It's a surgeon-controlled robot.
yeah, surgeon-controlled assistance of a robotic arm. That's really cool and really evolving. Obviously, medical management of breast cancer is evolving. Perhaps in the future, there will not even be a need for surgery. Maybe there'll be a pill. I mentioned all these new drugs coming out. Perhaps someday, literally, the cancer will melt away with the pill. As of right now, that is not the case. There are pills that help and injections that help, but they help prevent cancer from spreading or from coming back, but they don't necessarily, make it go away, where surgery usually is still needed. And then for reconstruction, a lot of people, myself included, are working on what we would call like bioengineered tissue. And there's different ways to do that, but what we're working on is a material, so a scaffold, if you will, that exists and then can hold fat. I mentioned fat grafting earlier. So in this way, you could take the patient's fat in liposuction and then mix it with this scaffold. Ours happens to be a liquid at room temperature. And when you put it into the patient at their body temperature, it turns more into a solid. Kind of a soft, sort of malleable, soft, fat-like solid, so you can sort of shape it and things like that. There are other groups also working on those sort of things where you mix fat together with some kind of scaffold or you inject it into a scaffold. And then you have now not a breast implant made out of silicone, but a breast shape, an implant, if you will, made out of the patient's own tissue, but not a flap where you had to cut out a big segment of tissue and hook up blood vessels.
Sure.
Just where you have this. Now, the whole trick to that is, can you get it to survive? Will it have blood flow in it? And will it perform the way you want it to, like natural tissue? That's what many of us are working on. I have a company related to this. Our company is in phase 1 clinical trials right now. So it is conceivable that in the next 5 years or so, we might be able to bring something like that for patients that don't have good options right now.
Yeah, so exciting. Gosh, that's really promising.
Yeah. So that's the bioengineered breast. That's the future.
Yeah, I love it. Well, Dr. Scott Hollenbeck, thank you so much for sharing your time with us and your expertise and giving the listeners such great insight about this big world of breast reconstruction. It's been wonderful.
Yeah, thanks, Regina. I enjoyed it, and hopefully it's helpful for people. And thanks for including me amongst your distinguished guests on your podcast.
Oh, you bet. Take care. Well, that's our show for today. Hope you enjoyed it and learned something too. Don't forget to subscribe, rate, and review. Please share this podcast with someone else who might be interested. And while you're at it, check out the podcast website for related topics to explore. It's www.plasticsurgerydecoded.com. And as always, thank you for listening to Plastic Surgery Decoded.